Hello, and welcome to lesson number 7 video. This lesson continues a in-depth conversation about the treatment process and delivering good treatment options to clients in need related to addiction. The book outlines the differences in the treatment levels. I will not go through that today, since your book does a pretty good job of that. But this section should serve as a really good preview of the types of topics that's discussed in HMS 260, Substance Abuse Counseling, that's offered in spring semesters. It's just a very timely and generalist overview of what we do study. What makes a really good treatment experience is an assessment that is continuous, holistic, and responsive to the needs of the client. What is an assessment? It's a conversation that's qualitative and quantitative, meaning you collect spoken information, narrative information from the client and family members, and you also want to collect data through a collection of surveys and tests, drug screens, and those type of things. And that assessment process doesn't end after the first day that you see the client. It continues throughout the treatment experience and even on into aftercare, and frequently before you ever see the client as well. The mistake that most agencies and professionals make is they perceive the assessment processes as one moment in time, just a singular picture of the client, and it's seldom revisited, with this assumption that the client's needs that they may have on the first day of the clinical experience is the same 6 months later, 3 months later, or the next week. And that's just not true. So if you're looking for a flow of how treatment works, there's generally an assessment. The assessment creates the treatment plan. The treatment plan is how it sounds. It's a plan of treatment. And that treatment plan informs us of the types of treatment and interventions to deliver. But we really can't do that without an appropriate assessment. An assessment lengths can take as short as a couple of hours to multiple weeks or months. One of the I believe inpatient treatment is overused, to be honest. Inpatient treatment is a very powerful experience for clients, especially clients who have had trouble finding sobriety in the community and being able to stay clean, and for other at-risk and dual diagnosis type of clients. At the same time, too many times we send families, especially, believe that they can send their family members to an inpatient facility and that will solve all of the world's problems, all of the family's problems and the client's problems. And so many of these clients have never had a good formal outpatient treatment experience where they see a therapist or counselor in their communities. Now you may say, Jamie, we just learned that there's a great shortage of outpatient facilities and therapists in our communities. And that's totally true. So many times families are forced with choosing inpatient treatment or nothing in their communities. And that's a very tough choice to make. It's even tougher when we realize our family member has spent 21, 30, 60 days in an inpatient facility. They need continued treatment and aftercare after they leave the inpatient facility, and the person comes home and those services are not available due to lack of funding or availability of service and those type of things. And that's extremely discouraging. And there's no good answer. No good answer. Your book talks about tough love approaches, which at one time was a really popular treatment approach in the 70s and 1980s, even early 1990s. This belief that in order to make progress with clients, we have to break them down and basically drive them to the bottom, then build the person back up. Those ideas have been somewhat discredited, but I do believe that we do have to have an equal level of consequence and rehabilitative services to encourage clients to get better. If we only provide treatment services and shield the client from feeling the consequences of their actions, success, in my experience, is very low. As is the same with the opposite view. If we only provide punishment and consequence, but we don't provide hope or treatment services, success in that fashion is very low as well. The author talks about motivational interviewing, which is not a treatment, it's not a counseling theory, but it's a therapeutic approach that's very similar to the work of Carl Rogers, and it's built on the work of Rogers. Motivational interviewing says that everyone is motivated for something, and usually for positive intent, and the role of the counselor is to help the client pull that motivation out of them and achieve the goals that they want to work on, that they want to achieve, that's important to them. And when clients resist, or when clients do not do the right thing, we don't fight them. We don't deal with that resistance. We just move on and find some other circumstance that we can build cooperation on. Again, motivational interviewing is a topic we discuss in depth in actually HMS 252, the class, the spring class that follows 151. We also talk about that in the substance abuse counseling course as well. Your book mentions cognitive behavioral therapy. I was actually trained as a cognitive behavioral therapist in my graduate school training. Practiced that for about 10 years. And to be honest, in retrospect, I believe it's an approach that's overused. It's built on questionable research and doesn't have very good long-term effects. We talk about CBT in subsequent classes as well. CBT, cognitive behavioral therapy, does show good results short-term with clients, but not such good results long-term. The basics of cognitive behavioral approaches was actually created by the United States Army during World War II in order to train GIs in boot camp and to help them improve their thinking process, control feelings of emotion, and to follow orders without questioning them from supervisors. So many times, and this is one of the issues I do have with your book. It's a really good journalist introduction to the field, but it's also written by someone who's never worked in the field. And Schiff does a really good job of reviewing the research and the importance of evidence-based practice and the family experience and impact on society in a relatively impartial and unbiased view. But he's also been led down this road by the field of addictions, that he believes, as does the field, that the only way to provide services is via research-based, evidence-based practices. And I have to disagree. Those are good skill sets to learn from, and we need to be able to learn from the research and the material. But instead of the research being the most important thing that we keep our eye on, I tend to believe it's the person in front of us. And if we implement skills such as motivational interviewing and those of Carl Rogers, and what AA and NA has taught us, and what we know about the disease of addiction, outcomes are no more better or no more worse, to be honest, than any of these evidence-based practices. And we will talk about, again, that in depth in future classes as well. Um, the book talks about group processes versus individual processes in terms of treatment. What's better, what's worse, and then that's based on individual need. For some clients, individual treatment is the only option due to their past trauma and experiences and lack of treatment opportunities. For others, group is a wonderful option. In a perfect world, we could offer both. The book also talks about medication-assisted treatment, which is really, really important, as well as different types of treatment called multisystemic therapy or family treatment that's frequently delivered in the home. Once upon a time, I actually supervised a MST, multisystemic treatment team in one of my programs. And we designed that treatment team to work with 16 to 19-year-olds inside the office and inside the home. It was actually a hybrid team of sorts. So we didn't necessarily stay true 100% to the model, but we did 75% to the model. It was a private effort and a public effort with local mental health. True multisystemic teams are not as common as they were in the past because they're very expensive. Usually the average cost for a MST team per year per client is over $45,000 a year. If the client has Medicaid, the last rate I talked with several years ago was over $60,000 a year for one client. You wrap around services of a therapist, a psychiatrist, a social worker, case manager, and in-home counselors. And your Medicaid money is paying for that. And unfortunately, for many of these clients, they were overdiagnosed for the sole purpose of drawing down federal funding to pay for the service, even though the assessment said the client did not need the service. And this is where treatment gets a bad name, and where folks become confused with the treatment process and concerned. Last but not least, your book talks about the AA process and what AA means and doesn't mean. I've provided some good notes about core and original documentation from AA. And in HMS 260, again, the substance abuse counseling class, we read the entire big book, blue book of Alcoholics Anonymous. And most students tend to enjoy that. In the meantime, let me know if you have questions and I'll be happy to help. Take care.